Population of about 140 crores, last year about 15 lakh people got cancer for the first time.
What percent of cancers are because of hereditary reasons? Like if your parents have got it, does it significantly increase your chances of getting it? And then second question is there a genetic component to it?
There is an abnormality called BRCA1 and BRCA2 which became very famous because of Angelina Jolie.
Absolutely.
Right?
She had a breast removed,
yes.
right? Even before you get cancer, you can have it removed.
The chance that a woman will get a breast cancer by the age of 60 is almost about more than 60%. To be very honest, no government can handle these kind of treatment facilities.
Lung cancer cases are absolutely on the rise globally as well as in India. What is the reason for that?
Theories which is propounded for cancers in people who are not obviously smokers or anything is chronic infection.
The private insurance in this country is so minuscule.
Yeah, absolutely.
And even within that private insurance, we are probably not getting enough coverage.
And what you can do is, there is something called a boost policy which goes up to 1 crore.
Reason for that in India is the nutrition, the pollution, the lifestyle and all of that. Because of that, it's a high incidence when you're younger.
And an epidemic of obesity.
Hello everybody, this is Namita Thapar, Executive Director of MCure Pharmaceuticals, and today we're going to be talking about a very important topic, cancer. 1 in 5 people develop cancer at some point in their lifetime. 1 in 9 men die of cancer. 1 in 12 women die of cancer. WHO did a survey of 115 countries and they have a report stating that there will be 35 million new cases of cancer by 2050, which is a 77% increase over the 20 million new cancer cases that we saw in 2022. This is definitely something that's on the rise, and we have an expert with us today who's going to help us understand a bunch of issues surrounding this topic. My dear friend, Padma Shri Dr. Deshpande, I know what a crazy life you have. You've just operated on somebody and come here. Thank you so much for your time. And I love the fact that being the head of a very important hospital, you've seen everything that there is to see. So I would love to start from the very basics, which is understanding what are the top cancers in men and women. And then for each of those, maybe we pick top 3 in men, top 3 in women. And then for each of those cancers, just digging a little deep to understand the symptoms as well as the diagnosis, as well as what you're seeing in the Indian landscape.
Namita, first and foremost is thank you very much for having me here. Cancer is basically quite a depressing topic because it not only signifies and it represents a sickness like any other sickness, but there's a lot of suffering which is associated with it. There's a long process of treatment, a lot of expenses which go on with it, and sometimes to the level of personal bankruptcy if you're not really well prepared with insurance and all the other things. The statistics which you gave actually are very, very important for that matter, for a few reasons. See, with a population of about 140 crores, last year about 15 lakh people got cancer for the first time. And normally about 3 to 4 times as many would be there who will have undergone a recent treatment or still recovering from the treatment and all that. So at any given time, you have about 60 lakh people. Now, can you imagine? That's probably population of Denmark. Right. So that's the entire population which is actually connected with cancer in the immediate past in our country. And this number in the next 10 to 15 years will increase from 1.5 million to 2.5 million. So cancer incidence is definitely growing, and it's becoming a little more difficult because if you really analyze what is really required to tackle this problem for treatment-wise, prevention-wise, rehabilitation-wise, to be very honest, no government can handle these kind of treatment facilities. Cancer facility is normally pretty technology slow and it costs quite a lot of money.
Right.
Today, there are about 350 to 400 centers which are known as oncology centers in our country. So we have a national cancer grid to which all these guys are members. We have almost about 700 medical colleges, which each one of us will have oncology department. And apart from that, every state will have at least 1 or 2 regional cancer centers. With all this, it's very difficult to treat every single patient who is going to get cancer. So that is the kind of resource allocation and
absolute gap between the demand and supply.
That is as far as the physical infrastructure is concerned. Number two is the human resources. See, to make an oncologist, be it a surgeon, a medical oncologist, a radiation oncologist, you have to undergo a long training, at least 10 to 12 years. Right. So you can't really produce an oncologist straight away overnight by just putting the person into a medical college. Right. So we don't have enough number of technologically qualified people. That's another shortage what we face in our country. So now, what are the various cancers which we are going? See, every country has its own profile of cancers.
Absolutely.
And in the country, particularly as big as India, the type of presentation will change from state to state. For example, if you go to North India, say Uttar Pradesh and Bihar and Northeast and all that, where tobacco is very, very predominant. Head and neck cancers are very common. Right. Upper esophageal cancers are very common. Stomach cancers are very common. So men cancer, the cancers in male are a little different because of their habits, their hormones are different. Women's cancers are a little different. Correct. The commonest cancers in case of men are prostate and lung. Okay. Yeah, the esophagus and then GI tract. Right. So these are the common cancers in men. In case of women, it's the breast and the uterine cervix, the mouth of the womb, as what we call. Right. Gastrointestinal cancers and ovarian cancer. These are the common cancers in case of women. Each one will have its own life cycle, curability and all that. And that will also change from country to country. Let me just give you a small kind of a changing pattern. See, the average breast tumor, which was actually diagnosed for the first time about 25, 30 years back, used to be about 4 centimeters. Okay. You can imagine the size of 4 centimeters. Right. That almost takes it into stage 2, stage 3 kind of a border. Today, the average tumor size is 2 centimeters or even less.
So it's getting diagnosed soon.
It's getting diagnosed early, but more number of patients are getting diagnosed.
Got it.
Because of several reasons. See, the cancer incidence is rising for many things. One is longevity is much longer now. You know, at the beginning of last century, the lifespan in India probably used to be in their 20s or 30s. People's life used to get over. When we got our independence in 1947, it was around 40 years or something like that. Today, the average lifespan for a man who has lived as a child till the age of 5 years, means the infant mortality is already crossed, is about 69 years. For a woman, it's about 71 years. Okay. So as you grow longer, something can go wrong in the entire system. Right. So that is one. Secondly, you are also exposed to the atmosphere for that long. So any kind of irritating influence, pollution, etc., you are exposed that longer. So your chances of getting a cancer keep on increasing. It's said that if everybody lives till say to 125 years, right, 80% of ours will get cancer by that time. So yes, we should live long, but please understand that it will come at a cost. So this is one part of it.
But one of the topics you didn't cover is the genetic part that we spoke about. You spoke about environment, you spoke about age. Right. But we discussed genetic and how Angelina Jolie got a genetic screening done and then removed a breast to avoid breast cancer. Is that also something that's becoming more prevalent?
Genetic is very important, but I'll tell you one thing, there are intrinsic factors to the body and extrinsic factors. Today, extrinsic factors are quite important because of this air pollution is there. Then occupational exposures like in asbestos, the radon gas, etc. Like radon is released during construction activity. So those workers who are working in construction industry, cement industry, etc., they're exposed to all that. So even if you don't have anything innately wrong with your body, the body is hammered down by all these carcinogens and then you can get cancer. Okay. And the more you are exposed, the higher are your chances. So understand one thing. People who are working in all these kind of industries, which mean that the middle class or even lower, the manual workers are more at a risk for that. Right. So this is very, very important. A very small portion, 5% of or less, will have an innate problem.
The
genetic problem.
That's 5% or less?
5% or less.
I thought it would be larger.
No, about 5% or less will be
hereditary.
Genetic cancer. Hereditary cancer is again different.
Let's talk about both.
Yes.
Because they're different. You're right. There's
they are grouped together
and
quite
there's
often.
genetic.
Yes,
so let's talk about both.
See, genes is something which is very, very definable. You know, we have 23 pairs of it, and there is a certain pattern in which every human being will have almost the same kind of a pattern because of your external morphology, right? Anything abnormal which is happening there can actually be identified, measured, quantified, and maybe and someday it may be altered to
Right.
prevent anything happening. For example, now there is a abnormality called BRCA1 and BRCA2, which became very famous because of Angelina Jolie.
Absolutely.
Right?
She had a breast
So,
removed,
yes.
right, after
No,
the
but
screening.
the thing is, her mother as well as her aunt, mother's sister, both had cancer ovary and cancer breast. And
Okay.
that's how the whole thing came to be diagnosed.
And she basically
Yeah.
removed her breast before she even got cancer.
That is a preventive surgery. Now
Absolutely.
we have a section called preventive cancer surgery, where you know that you are likely to get cancer because of the genetic abnormalities. So you have this breast replacement, you have removal of stomach, you have removal of colon.
My
several
God.
surgeries are available, and they are opted for also.
Which are the areas? Let's go over it. You said breast,
Breast,
colon,
stomach, yeah, stomach and colon.
These are the three.
Yeah, these are
then
the
you can,
three.
even before you get cancer, you can have it removed.
Before the cancer manifests itself, because the incidence of cancer occurring in these genetic abnormalities as high as 80%, which mean that, for example, now let's talk about BRCA1 and BRCA2. The chance that a woman will get a breast cancer by the age of 60 is almost about more than 60%.
Wow.
So if that is the kind of a thing, then ovarian cancer is almost 50% by the same type of age. So what do you do in this kind of patient? Suppose a lady who is 25 years comes, she says, my mother has a cancer breast and she is BRCA1 positive, then we would test her for BRCA1 and she turns out to be positive. We don't do anything immediately. Understand? Because both the breast and the ovary have a use.
Right.
And the incidence of malignancy starts going up after the age of 40.
Okay.
So you ask the lady to, complete her family, feed the child with breast milk. There is no problem in feeding breast milk, even if you are BRCA1, BRCA2 positive.
really?
Yes, yes.
Okay.
There is no transmission of cancer or anything like that. Okay. So once you reach nearly between 40 and 50 years of age, you can undergo the breast removal. Now, conceptually, what we think, breast removal means everything goes flat. It doesn't. Angelina Jolie, it looks exactly the same. So what you do is you actually empty the whole contents of the breast, keep
Right.
the nipple and areola the same,
Right.
and you put either a prosthesis or a muscular a flap or something. Cosmetically, it will look exactly the same. Feel-wise, it will almost be the same. And if you used a prosthesis, then that lady will probably have a non-sagging breast for the rest of her life.
Oh my God. That's
Yeah,
fantastic. So you're an advocate of preventive surgery if genetically you're predisposed
Absolutely.
to it.
Because at the same time, we also advise removal of the tubes and the ovary.
Okay.
So that is the little, breast removal, yes, you have to undergo surgery, 10 days of surgery and then, physiotherapy and all that. It's not really so bad.
Right.
But if a lady is not having a menopause and then suddenly you take out her ovaries, menopause is a process of 2 years.
Right.
And then, the hormones go down slowly and steadily. Mood changes happen slowly and steadily.
Correct.
The hot flushes, the temper, all that thing is, the lady gets time to get adjusted.
Right.
Here it's like one stone hit.
Absolutely.
So that is a bit, it needs a little more of adjustment. A lot of counseling is done for these kind of people. At the same time, you need to tell them about the benefits also. On the other side, when you're talking of familial cancers,
Right, hereditary.
there are certain conditions where genetically there may be no abnormality.
Right.
But you find that certain cancers run in some families. We still don't know why. We may find some reason someday for that. But for example, a colon problem or a stomach problem, and these kind of things, they run in families.
When you say run in families, means your parents have to have it, or it can
Parents
even be aunts and
first
uncles?
relatives, their siblings or your parents or your siblings, somebody or the other may get that particular thing. Now there's another third type also. Somebody comes and says, see, my grandfather had lung cancer, my father and his brother had lung cancer, and now I'm diagnosed with lung cancer. So either I have genetic predominance or I have got a familial cancer. You just need to ask them one thing. Are you all smokers? And if they're all smokers, it has nothing to do with family. It's something to do with your habit.
You
Yes.
called for it. You asked
called
for
it. You asked for it.
Yeah.
So this is, a few questions. That's why clinical history is very, very important in these kind of things.
But let's just take a moment for what you just said, lung cancer. I had a very dear aunt who died of lung cancer, and obviously she never smoked a day in her life. And she lived in the US, in LA, which is one of the cleanest, you can't even say it's environment or pollution. Lung cancer cases are absolutely on the rise globally as well as in India. What is the reason for that?
See, many of these cancers are plain and simple bad luck. But there is so much of pollution which is coming up. there is so much of chronic infection. And one of the theories which is propounded for cancers in people who are not obviously smokers or anything is chronic infection. Now the chronic infection could be bacterial or even viral for that matter.
Okay.
Now there are so many things which are in cancer. We still don't have answers for everything. And research ultimately it's a constantly moving field. So research will throw light someday or the other on that. But it is happening, and we'll probably find the answers someday.
And let's jump into this research bit. So, I'm fascinated by this whole targeted therapy in terms of cancer cure. And a lot of people don't know about targeted therapy. They don't know about CAR T.
Yeah.
They don't know about immunotherapy, especially Pembrolizumab that cures 24 cancers
Right.
at a time, the most promising drug. Can we talk a little bit about, the research as well as the work around some of these new treatment options and how they're really changing the way cancer is being looked at in terms of treatment?
Yeah. See, if you want to really trace the treatment of cancer, one of the first treatments which was done was actually surgery. The first treatment for cancers, they all started with surgery almost over 100 years back. 1882, 1885 and all that major surgeries actually came up during that particular time, and that coincided with the discovery of anesthetic. Otherwise, people used to just, they were given alcohol and people would cut the limb or something like that, maybe chop off a breast if the breast looks abnormal,
Right.
something like that would happen. But it was not a very scientific kind of a thing. All this scientific, we see, unfortunately, we don't have the data of Sushruta, who was the father of Indian modern medicine, and that is 600 BC. So if we had that data, then we probably would have had a sense of continuity. But in modern science, everything started in the late 1800s, early 1900s. So then actually the anesthetic started getting improved. So various types of surgery started coming in. Then the surgery slowly and steadily, people started realizing, all right, it may not be really necessary to take out an entire organ. Don't have to take out an entire lung to cure that particular part of to cure that malignancy.
Correct.
And you can just take out a small lobe. Then now what we do is we take out 1 centimeter on each side and we just take out one segment, which is like 1/19 of a lung.
Correct.
You can take out, which you just don't. It's like taking out a small change from your pocket, which you will not realize,
Right.
and you will cure you of your cancer. So this is what is happening as far as surgery is concerned. The minimally invasive surgeries, like we use telescopes, maybe you use a robo. The surgeon monitors and the managers maneuvers the robo, and then the same surgery is done. Recovery is much faster, pain is less, the long-term results are much better, and the radicality continues to be the same. Radiation therapy started at the beginning of last century with Madame Curie when they identified how radiation actually helps. Then technologically the machine started keeping on getting modified and modernized. What is radiation actually? It's literally like burning of tissues. So initially it was like a torch. Like you would have a cylinder of torch, the energy going,
Correct.
and then burning that whole entire area.
Correct.
So not only the tumor, but the surrounding area also would get burned. It is the
Absolutely.
collateral damage.
Right.
Okay. So all the modernification which has come is how to avoid the damage to the collateral damage to the surrounding organs.
Right.
So now we have the cyber knife, etc., which integrates the highest level of computerization and the covers which are there, in which case the entire three-dimensional irregular obnoxious kind of a tumor can be eliminated. Much higher dose can be given, and the collateral damage to the surrounding area is only 0.6 millimeters.
Okay.
So you are just not doing anything, no damage to the surrounding organs.
This would be an example of a targeted therapy.
No, this is targeted radiation therapy.
Targeted radiation
Yeah.
therapy. Got it.
Chemotherapy started in the Second World War.
Right.
After the Second World War, nitrogen mustard gas was that from that time onwards it started, and multiple drugs started coming. So chemotherapy is like any other medication. For example, when you get a headache, you take an aspirin or something like that.
Right.
I don't think many people will realize that you take 1 tablet of aspirin, you lose 3 cc of blood in your stomach.
Okay.
You don't even realize it,
Yeah.
because it's no bother at all.
Right.
But as the drugs start getting stronger and stronger, you do address the disease, but you also have a lot of side effects. Your bone marrow gets suppressed, your blood counts go down, you have a gastrointestinal toxicity. Some of the times, the kidneys get suppressed, liver gets suppressed. There's a lot of side effects that way. And the reason is, while killing the tumor cells, you're also damaging the non-cancerous cells.
Correct.
Okay? It's
That's
like
again the collateral
it's
damage.
like an anti-terrorist operation where even the lay people are getting shot.
Right.
It should not happen.
Right.
So when you're looking at a professional kind of a team which is handling the things, they say that collateral damage should be ideally zero.
Got it.
Sometime in 2009, the scientists actually kept on for trying to find out, is there any way that we can damage only the tumor cells? And then they start getting into the molecular diagnosis and the basic metabolism of the cells. And that is how they started identifying the targets.
Okay.
So if you have certain targets, like there is an abnormality in a cancer cell called EGFR. So if you have a cancer, say lung tumor cell, which is EGFR positive,
right,
then what you do is you block that particular EGFR, that cell will die.
Okay.
So, and that EGFR abnormality is expected to be there only in cancer patients,
right,
in lung cancer patients. So you can, even if the lung cancer is advanced, you can actually get a lot of life from that. The average survival for a stage 4 malignancy, which means that you have a lung tumor and you have a cytopositive effusion,
right,
fluid in the lung, the survival would be anything from 6 months to 1 year, and you would just tell the patient to go home and get lucky, spend your time happily for whatever it is worth. Today, if that patient is EGFR positive, you can give 8 to 10 years of life to that particular patient. You can imagine. See, one thing very relevant in our country as compared to the Western countries, right, is in Western countries, the incidence of cancers, any type of cancer, is more in the 6th and 7th decade of life, okay, by which time everybody has retired. And as such also, their children are not dependent upon them. So they go their own way. By that time, everybody is settled. Your family is all settled. Everything is fine. Cancer incidence in our country is more in the 4th and 5th decade, where the man or a woman is actually a pillar for that entire family. Children are still small. They are dependent. And if the arrangements are not been made, even if the arrangements are made,
it's a real crisis.
It's a real crisis. The sociological crisis is tremendous.
What is the reason that there it's in 60s, 70s, here in India it's 40s, 50s? What is the reason?
It's just that probably we are built that way. We are
so
exposed.
There's no cause. It's just a genetic
we
or
are
the way
exposed
we
to
are.
so much of pollution.
Okay.
Plus, we have our own habits. Our nutrition is not as good. So that is the thing. See,
there's proven data to show that in the West it's more 60s, 70s. In India, it's more in 40s, 50s.
Yeah, it is there. All the data is available.
Publication.
Yeah, see, these 15 lakh people who have got the highest incidence is between 40 and 60 years of age.
Got it.
Abroad, the same thing is between 60 and 80 years of age.
Understood.
So
Understood.
all the
that's all the more reason Indians have to be better about their early diagnosis.
Correct.
And knowing the symptoms.
No, not only that, the incidence of cancer in people below the age of 50 is rising. After all that data, below the age of 50 is rising. And the diseases are becoming more virulent.
And you're saying, let's just pause here for a minute. You're saying the reason for that in India is the nutrition, the pollution, the lifestyle, and all of that. Because of that, it's a higher incidence when you're younger.
And an epidemic of obesity.
That's a very important
factor. We are a poor country with an epidemic of obesity.
Right, right.
See, obesity and combined with diabetes, 10% of our population are either actually diabetic or pre-diabetic.
Understood.
It's like huge amount of population. It's like almost half of American population.
So these are the big causes of this age.
Absolutely big causes of cancer.
Getting it earlier.
Yeah.
Okay, coming back to our discussion on targeted therapy. So you spoke about targeted radiation therapy. Now we were talking about targeted chemotherapy.
Correct. Medical therapy, yeah.
Right.
So these are various medications. So you test the particular tumor tissue, identify if there is a target which you can actually identify, and you can treat it with it, and then you give those medications. Now the problem is, yes, your results are very good. Many companies are actually manufacturing these kinds. See, most of the time these original research molecules are all patented.
Right.
And when the patent runs out, you can actually manufacture. For example, this EGFR medicine earlier used to be like 70,000, 80,000 rupees a month.
Right.
Now you can imagine 70, 80,000 rupees a month.
It's a lot.
For one person's treatment per month in a family is going to be very difficult.
Yes.
Today that thing has become much cheaper. It runs, just maybe about 3,000-4,000 rupees, which is
because it's gone off
workable.
patent. The main drug is gone off
because it's gone
patent.
off patents. But scores of medicines are still under patent, and they are just not available. They have to be imported, and then they are very expensive.
Which are some of the common medicines which we have to import for, very prevalent cancers, which are not off patent and which absolutely become a treatment of the elite and the common man cannot
They are
be
more
treated.
today. They are more in the domain of immunotherapy.
Okay.
Immunotherapy, this Pembrolizumab, what we were talking about, and the Nivolumab, and all the other varieties of the immunotherapy, they are all within in the patent domain.
So what is immunotherapy? Let's take a step back and understand in layman terms what is immunotherapy as a treatment option for cancer.
Immunotherapy is something which actually makes your own body's immunity stronger. You have those lymphatic cells, you have the white cells which are there. They are actually strengthened. It's like you create an agency which actually makes your police, your home guards, your defense force, not the actual army. Army is very strong, but all these people as strong as the army, so that the crime goes down domestically. So same way, your own cells, when they become stronger, then that adds to all the other effort that what you're giving. So you can combine immunotherapy with chemotherapy or with radiation therapy, and your results are definitely going to be much better.
Now, so regardless of the type of cancer, since like Pembrolizumab treats 24 cancers, for all 24 cancers, it would be something that you give along with your chemo and your radiation.
You can, but again, there are what we call as, just as targeted therapy has those targets, like that you have checkpoint inhibitors. PDL1, that is the name of the programmed death ligand. It is called programmed death ligand. So that actually, if that is positive, Pembrolizumab is the drug for that. You understand? But even Pembrolizumab costs 2 lakhs a month. So that's a huge cost again. Companies come up with various schemes and all that, but
it's never enough.
These drugs still need to be imported, but the amount of life and the quality of life that it adds is really amazing.
Are all immunotherapy drugs on patent, or many of them are off patent?
Most of them.
So it's fair to say that immunotherapy is a treatment option in cancer, where in layman terms what you're saying is it's equipping your own body to do a self-defense.
To fight the cancer cells.
This as a treatment option is fairly new. Like how many years back was this started?
This is less than 10 years.
Less than 10 years back.
See, the targeted therapy, what we spoke about earlier, started in 2009. Which is barely about 15 years back.
Absolutely.
And this is less than 10 years. So, and ultimate in immunotherapy is what we call as a CAR T cell therapy.
I wanted to understand that because we hear so much about this CAR T cell therapy. What is that?
See, we have various cells and lymphocytes which actually are meant for chronic protection of our body. So there are certain cells called T cell, the killer cell. They are called T killer cells. So what you can actually do is, see, when you treat a bacterial infection, what do? You ask somebody to cough out, or if there's a pus or something, you take some pus and then you culture it. So you have a culture of the bacteria, and then you run the test against certain antibiotics. So they are matched, and which is the best antibiotic for this particular one, and then you use that antibiotic. So culture is done, and then you use that particular antibiotic. So what is done in case of CAR T cell therapy is you take the antigen from the tumor, which means that you need a biopsy, and then you take the cells from the human body, which means that you need the blood from that particular person. The whole thing is put together in the lab, and then you multiply these T cells, as many as possible. You expose them in such a way to the tumor cell that they become T killer cells.
So you put them back in the body?
Yes. The principle of this is very, very straightforward. See, in our body, cancer cells are being produced throughout our life. And they are being taken care of. They're being taken care of by the ordinary the white cells, the lymphocytes, and so on and so forth. There are multiple. It's exactly like what happens in law protection. There are several agencies. But what happens is, the thing is, the cancer cells also are your own cells. They behave exactly the same way, but they are very obnoxious. Their ultimate behavior is completely different. So unless and until there are cells which can identify that, look, this is an abnormal cell, and retains that memory. That memory has to be retained. The T cells are the only ones which retain that memory.
It's almost like artificial intelligence.
I think natural intelligence at its ultimate.
Okay. So let me understand this in layman terms. There are T cells in our body. You will remove those cells. you will multiply them.
Correct.
You will put these receptors on them. Then you will put them back in the patient's body.
Correct.
They have a natural intelligence, they're almost like an army or the forces that will go in back in the body, look specifically for the cancer cells,
yes.
and then target those in terms of what exactly are they then doing once they target the cancer cells?
They kill those
cells.
Yes.
So it's literally like removing these cells,
Yeah.
Training them to become an army,
Yeah.
putting them back in the body and saying, go and
It's
kill
like
those,
sending a commando
cancer
force,
cells.
sending a commando force
Right.
in search of those criminals, and they'll identify only that there is hardly any collateral damage, and they kill all those cells.
But I've heard that CAR-T cell therapy is currently being used only for 2 or 3 types of cancer, because
Yes.
for the other cancers, the research is still being worked on.
Correct,
Is that
correct.
true?
That's right. It's still used only for lymphomas and leukemias and all that.
Right.
Solid tumors, it's still not as effective as what we just
But in our lifetimes, hopefully at some point, we
technology will change, and
More research is needed on that.
Yes. And on the other side, if you see, there are vaccinations against cancer. For example, there are certain viruses which cause cancer. Human papilloma virus
Cervical
causes the
cancer.
cervical cancer. The hepatitis B causes the liver cancer, etc.
Correct,
So if you vaccinate against them, then automatically these cancers
those are 2 easy vaccines. For cancer.
Apart from that, there are specific vaccines against the tumor cells in prostate and in colon, where after treatment, actually, which means that in a reasonably medium kind of a stage when a patient is treated, if you treat them with these vaccines, the chances that the tumor will come back go down further.
Okay.
So those vaccines are there. Till date, we don't have a universal kind of a cancer vaccine that, okay, you give a vaccine, patient will not have cancer. We don't have that. Highly unlikely that it will happen.
Right.
Because,
I want to pick on one topic here. So, you mentioned about how vaccines, especially in prostate and colorectal, will make sure there's no recurrence, right? Mid-treatment when you give these vaccines. So, there are more mid-treatment vaccines rather than preventive vaccines. Let's talk about recurrence, because we hear that in certain types of cancer, the probability of recurrence is much higher than in other types of cancer.
Correct.
So, let's limit our discussion to those 5 or 6 that you mentioned earlier that are the top cancers in our country.
Yes.
We spoke about breast, we spoke about lung, we spoke about gastro, which could be pancreatic or colorectal. We spoke about prostate, right?
Yeah.
So if we pick these 4 or 5 cancers, which are the topmost in our country, talk about recurrence a bit.
See, the recurrence chances are dependent upon many factors. One is the innate character of the tumor itself. For example, breast cancer is very easily diagnosable, and easily treatable also. So chances that it will recur after treated properly are much less. For example, what we say is a non-palpable breast cancer diagnosed only on a mammogram, which means that you don't feel anything, but then you do a mammogram, you find a small nodule there, 2 millimeters, 3 millimeters, you treat it. Chance of cure, which means that the thing doesn't come back, is 97%.
Very high.
Probably I think that 3% risk is negligible. You cross a road here, your chance that you will meet with an accident is much more.
Very true.
So that is one. Number 2 is the basic characters. The biological characters based on the biological markers on that particular patient, on that particular tumor. For example, breast cancer is tested for hormone receptivity. Right. It is said that most breast cancers are hormone dependent because of the irregularity occurring with each period in a woman.
Right.
The incidence of cancer of breast is more in women rather than men. Okay. So if you have a completely hormone receptor negative tumor, that tumor is likely to recur more. Because the biological character of the disease itself is aggressive.
Got it.
You don't have a controlling factor. What we do is you treat the patient by surgery, give her radiation so that the rest of the breast is all right, and then to prevent anything from occurring, for next 10 years you give a hormone which suppresses that estrogen rise.
Understood.
So that way you can keep everything under control. What do you do for a tumor which is not receptive to estrogen right from beginning? Obviously, there is a higher chance of a recurrence. So you give them chemotherapy for a longer period of time.
Understood.
But you can't give chemotherapy for the rest of the life.
Right.
So obviously, these patients are not going to do as well as the hormone receptor positive.
Understood.
Unfortunately, triple negative cancers are more common in younger patients who need to live longer.
And triple negative cancers are the ones that are most aggressive.
Most aggressive,
right?
Yes.
I mean, they spread very quickly.
They spread very quickly, they are resistant to treatment, or they recur more.
Right.
And they occur in younger patients who actually need to live more.
It's the recurrence
so,
is a bad thing, because they have a much longer lifespan left. Okay.
Then there are other cancers which are located deep. For example, pancreatic cancer.
Right.
It doesn't really manifest very early in stage.
My grandmother had that, and till the last minute, till a month before she died, we didn't know she had pancreatic cancer.
Right.
And then it's sudden.
Yeah. No, the sudden is basically because the symptoms occur suddenly. It's not that the tumor was not there.
What are the symptoms of pancreatic?
Pancreatic, it comes into multiple this thing. It can be a loss of appetite. It can be a pain in the epigastrium or in the back.
Right.
Jaundice. And gastrointestinal, digestion problems, so on. All these
so
things
by the
are
time
common.
these symptoms manifest, it may already be stage 4.
Plus the location. Right. What happens is, by location, cancer which is there in the head pancreas causes a jaundice reasonably early because it stops the flow of bile.
Right.
So even if it's in the early stage, it will cause that nuisance. So it starts shouting, hello, I'm here. And then you treat it.
Right.
And then the chances of cure are much more. But a cancer which is located in the body and tail doesn't manifest itself very early. So it's very likely that you are not going to be able to treat it radically.
Other than pancreatic cancer, which are other cancers where you will not really notice these symptoms probably till it's very late?
See, anything which is occurring on the surface or in the accessible areas of the mouth, or something which causes symptoms in the rectum, these are the things which are reasonably diagnosed early. Anything which is there in the chest, for example, a lung cancer, a mediastinal tumor, these are the things which don't really manifest very early. Esophageal cancer can manifest, it's a medium kind of a thing because it will cause difficulty in swallowing, so the patient is likely to go to the doctor.
Right.
Pancreas is one, liver is another one. You can have a huge tumor in the liver without realizing what it is. Colorectal cancers quite often have a presentation like anemia. You may not have any constipation, particularly the right-sided tumors. You can have anemia. So they go to the doctor, and if the doctor is very sensitive, alert, then he'll investigate the patient immediately. And today what is happening is, there was a time when sonography used to cost thousands of rupees.
Right.
Today it's available for a few hundred.
Right.
So everybody does sonography, a chest x-ray, routinely these things are being done.
Right.
Apart from that, the awareness is more today. The preventive checkups are more.
Right.
You go to a doctor, he runs into executive checkup. The accessibility of health facilities.
No, but let me just interrupt you here. You said something alarming. You said they could be having anemia.
Correct.
Because usually colorectal
unexplained anemia.
Yeah, colorectal could be like, trouble passing stools or bleeding. And you're saying it on the right-sided colorectal cases,
Correct.
It could just be anemia.
Absolutely.
Now you have to have a doctor. You would probably go to a consulting physician as your first point of contact. The doctor has to be alert enough
Correct.
to know that anemia could be correlated to colorectal cancer and not just give the iron tablets and khatam karo.
Absolutely.
Second case, I remember I met Dr. Prashant at your hospital. He said the same thing. A lot of people go with ulcers in their mouth to a dentist. And the dentist again has to catch it early.
Correct.
Saying that, this ulcer could be head and neck cancer.
Correct.
Now, my question is coming to, it's different when they go to an oncologist or an expert like you who's got those 12 years of education. When you're going to just a common CP or a dentist with an ulcer or anemia, how do they catch these cancers?
In every medicine line, even in not only in allopathy but even in Ayush medicine, all these things are taught. And ultimately, how well you absorb that, it depends upon your alertness. So how professional you are, it depends upon your own alertness and how well you have absorbed your science.
There must be multiple cases where a dentist or a CP, dentist is not catching the ulcer and the CP is not catching the anemia.
Even consultants, by their not being aware, we get cases which have actually got neglected and gone to a higher stage.
This is the scary part because we always talk about patient education and that patient should learn about self-breast examination to figure out the lumps or these other things, right?
No,
but there's so much doctor education that is lacking in that dentist figuring out the ulcer could be the cause of cancer or anemia could be the cause of cancer. And there's nothing we're doing about that.
We have a continuing medical education at all levels, from general practitioners to consultants.
Is it happening?
Yeah, regularly. All over the country it happens. All over the world.
That's reassuring to hear because I'm thinking about Gen Next and I'm thinking about the level of training, not just at your expert level, but at a CP level. Is that
continuing? It's continuously happening.
Okay, so that's good. Now assure me about one more thing. We said we'll talk about survival rates as well, right?
Yes.
So you educated us about recurrence rates. Let's talk about survival rates. Which are the cancers which have a much higher breast cancer? You said if
Breast
it's
cancer, colon cancer is reasonably good
because
to
it's
treat.
just chopping off those pieces through a
and then-
surgery and
yes,
removing the
yes,
cancerous
yes,
part.
Yes. And even it's easy to treat it even up to stage
Prostate
2.
as well, right?
Prostate also is a very good thing to treat. So all these, see, ultimately what even lung tumors for that matter, if there are various different types of lung cancers.
Right.
There are tumors called carcinoid, which are like if you radically remove them, almost 97% cure rate again.
Right.
But there are lung tumors called small cell lung cancer, which is very, very aggressive. So even if you treat them, quite often they recur. So that is exactly what happens.
We heard the statistics. 1 in 5 of us are likely to get it at some point in our lifetimes. Let's not assume we're going to be the lucky 4. Let's get prepared. Let's get educated. Let's get that insurance cover and hope this little attempt of ours at learning about this very massive topic frightened you a bit today. I think the goal was to scare our audiences a bit today.
No, educate.
Sometimes fear is a good thing.
Educate
Sometimes
them,
fear is a
educate
good thing.
them.
I think the mom in me is speaking,
Yes.
but I think sometimes fear is a good thing. It's healthy fear. Get educated, get that insurance policy. We wish you a very happy and healthy life. Thank you.